Okay, so now the webinar is starting to record and we'll let people come in. Okay, I'm trying to see. Welcome everyone who's a few minutes early. We're going to just sit tight until 7:15 before we get started with the presentation. Let's see, we have about 10 to 15 more people coming.
So I guess you can see the attendees on your end. I don't think I could see them on my end, but I guess if they have questions or anything, they'll put it in the chat or they'll tell you.
I'm a little confused because I don't see anyone else's squares either. So if anyone else finds that to be a problem, because this is my first time hosting, so please let me know if maybe all the attendees can see each other and we just can't see them.
I see. Okay.
Okay, and let me make sure that, okay, and the chat is open to everyone now. So feel free to write in the chat. I'm gonna see if there's something else I'm supposed to do for that.
Okay. Let's see. Chat is the same.
Okay, I see that.
Okay.
Okay, thank you, Lisa, for that information. That on the webinars attendees aren't seen. So that's good to know that this is as it should be. Okay, we'll just wait one more minute, give people some time to sign in before we get started. I think the chat should be working now, but thank you for using the Q&A to send questions and well, updates about the webinar.
Oh, my water.
Sure, no problem. And then we'll get started. Okay, should we get started? And
Sure.
people will come in as the introductions are happening. All right. Well, good to see you all. Welcome to tonight's Suffolk County Psychological Association webinar. Tonight, the topic that we are discussing is ketamine-assisted psychotherapy, which is one of the several forms of psychedelic-assisted treatments that is gaining traction in recent years. And my name is Laura Colantuno. I will be the host tonight. And we have Dr. John Catone here, who will share about his experience and work with ketamine-assisted psychotherapy. So first, I will give a little introduction about Dr. Catone before we get into the webinar itself. So Dr. John Catone is a psychologist in private practice in Stony Brook, New York, and a clinical assistant professor of psychology at the Renaissance School of Medicine at Stony Brook University. He is the author of numerous peer-reviewed research papers on the neurological correlates of mental illness, psychotherapy outcome, and most recently on ketamine-assisted psychotherapy. He is also a regular contributor to Psychology Today and Choosing Therapy, and has had psychology-related publications in the New York Times and the Washington Post. Also, Dr. Catone has been gracious and generous in providing us with his most recent publication in the Psychodynamic Psychiatry journal on ketamine-assisted psychotherapy. So we'll be able to have that article, all the attendees, as well as handouts and slides from tonight's webinar. I believe that covers it with the introduction. Anything, I think, and oh, we will be taking questions throughout the webinar. So if something comes up and you want to ask a question, feel free to write it in the chat if that works. If it's not, let me see
I
if,
think I can
oh,
see
it's
the chat
working.
a little
Okay.
bit more easily than the Q&A. I think I have to
Yeah.
actually click on. And then, you know, if you
Okay.
want to, you could always stop me whenever I typically like a more casual type of presentation environment. So it's a little, this is just for everybody's knowledge. This is my first webinar that I've given. So it's the first time, like, I can't really see the attendees and whatnot. So, you know, I'm just giving it to a screen basically of myself and Laura. So, you know, I apologize if it's a little wonky at first. This is, you know, it'll be something to adjust to, but like I said, it's, you know, it'll help to keep it a little bit more casual. If you have any questions, you could just filter them through the, you know, during the presentation. And then, you know, of course, at the end of the presentation, if you have any other questions, feel free to, you know, ask or type them in or whatnot. So,
Wonderful. Yeah, so feel free, and I'll keep an eye on the chat, and we'll get those questions either during or after if you want to wait for the end. And I'm just going to mute myself and take it away.
right. All right. Thank you. Thank you for having me, Laura. And this is really exciting. I'm really happy to get the opportunity to talk about something that has become a much bigger part of my practice over the last couple of years than I could have anticipated. It's been pretty remarkable how this has taken off, I guess, nationwide, really globally, but you know, even in just this area, our area of Long Island, and in my practice. So I know that this is, in addition to a webinar and a talk, there's also continuing education credits that are being offered for this talk. And there'll be, I think, a quiz that somebody's going to be administering at the end for the continuing education credits. So apropos of that, you'll notice that during the presentation, there'll be certain, let me, oh, hold on one second. Okay. So there'll be certain words or parts of text that are in green, and the words or the items that are in green you should pay special attention to if you're taking this for continuing education credits, because those will have special relevance for the quiz that you'll be taking. I also sent out, hopefully all of you received, I sent out a couple of resources. One is a summary of this talk that goes into greater detail than what the slideshow does. And then the other resource is a copy of the publication that I just had in Psychodynamic Psychiatry. And so, both of those hopefully were sent out to you. If not, my email address is, I can give that to you later. But in the summary that I sent out, you'll also see the answers to the quizzes are, relatively easy to find. I tried to make it, as easy as possible for people. So I guess my talk here is kind of broken up into really two parts. The first part is talking about ketamine in and of itself, its history, how it's administered just in general. And then the second part is focused more on ketamine-assisted psychotherapy. And so depending on the timing, I might give a 5-minute break in between the two parts, or if we're running long, then I might just go straight through. I'm going to try to save some time for questions at the end as well. So let's just start from the beginning with ketamine. So what is ketamine? So ketamine was developed in the early 60s, 1962, as sort of a safer alternative to existing anesthetics and analgesics, particularly PCP, phenylcyclidine, which was predominantly used at the time. It got FDA approval in this context in 1970 and was used extensively in the Vietnam War. That's why I have our MASH picture up there for those of you who are fans of MASH. We have Hawkeye, perhaps getting ready to do some surgery with ketamine. Actually, I should take that back, because now that I think about it, MASH, I believe was really about the Korean War, if I'm not mistaken, even though it aired on TV during Vietnam. But all right, we'll put that detail aside. Anyway, so it gained FDA approval in 1970, but strictly for use as a surgical anesthetic. Then, not too long after, in the late 70s, 80s, and 90s, psychiatrists and other practitioners were using ketamine off-label for psychiatric purposes, particularly depression and in some cases PTSD. And there are also anecdotal reports, both in the literature as well as among people that I know who are paramedics, that people started getting an understanding that ketamine had these antidepressant effects when it was administered by paramedics in crisis situations where people might be on the cusp of committing suicide, at a bridge, ready to jump, things like that. And they were discovering that not only was it sedating them during those moments, but they were having a period afterward for several days, several weeks later, where they were experiencing the antidepressant effects of ketamine. So the way things often work in medicine and in psychiatry is that doctors, physicians have pretty wide latitude for being able to use drugs off-label in ways that they see fit. And in some cases can solicit the use of a compound pharmacy to compound drugs that they use off-label in different ways, in different contexts. In terms of how ketamine works physiologically, so in the 90s, we were, for depression, we were predominantly using drugs that modulated serotonin, obviously the SSRIs. And the SSRIs were after the tricyclic antidepressants, which predominantly modulated norepinephrine. But the efficacy of those drugs, though better than what had come before then, still weren't as significant as we had hoped. And so psychiatrists started tinkering and experimenting with ketamine, which predominantly affects glutamate, and in particular the NMDA receptors of glutamate. Now, it's really kind of complicated because all the neurotransmitters in our brain are interrelated with each other and they interact with each other. So what happens, interestingly, is that they believe that the full mechanism is not really totally understood, but they believe that ketamine antagonizes the NMDA glutamate receptors, and then that suppresses further inhibition of GABA producing neurons, with an ultimate end result of excitation in the glutamate system. Like I said, it's kind of complicated and interrelated, but the interesting thing, though, beyond just the physiological action with the neurotransmitters, is that a number of the psychedelics, ketamine included, seems to show the potential for neurogenesis and synaptogenesis. So essentially what that means is that new neurons and new synapses in the brain seem to be developing in response to the use by these psychedelics, ketamine, psilocybin, and some of the others. Okay. Go ahead, yes.
We have Tony who has his hand up, and so just wanted to, should we take a question?
Sure, go ahead.
Okay. All right.
Hey, Tony. Okay. Oh, your mic is off, Tony.
I'm trying to.
Oh, there you go.
I'm sorry, John.
That's all right.
I leaned on the button. I apologize.
No problem.
Okay.
No question just yet. Don't worry.
Oh, all right. It's good to hear from you anyway, Tony.
Okay.
Sorry to interrupt.
That's okay. So, all right, let's see here. Just need to minimize this a little bit. Okay. So what we have here is the chemical structure of ketamine. On the left, we have what's known as racemic ketamine. So the version of ketamine that was developed in 1962 that is used for surgery is called racemic ketamine. And that is, I guess, for lack of a better word, the complete ketamine. But if you see the picture on the right, there's a picture of two hands, right? And I have my hands up here. Racemic ketamine is comprised of two, what they call enantiomers or isomers, and they're mirror images of each other. And so when you put them together in this way, right, they perfectly match up with each other. But they're different. If you put them together in the other way, you could see they don't match up, right? So that's why they came up with the hand metaphor to kind of explain this. And sometimes you'll hear them talk about right-handed ketamine versus left-handed ketamine. More officially, the two versions of it are called R-ketamine or R-minus ketamine, and the generic name for that is R-ketamine, if you could see there, A-R-K-E-T-A-M-I-N-E. And the left-handed version is called S+ ketamine, or the generic name is Esketamine, E-S-K-E-T-A-M-I-N-E. And now, what has happened is, so the racemic version of ketamine being the version that was FDA approved for surgery in 1970, that's the version of it that was predominantly provided off-label by psychiatrists in the 70s, 80s, 90s, and even to the present. And from my experience, I think that is the most effective form of ketamine for psychiatric purposes. However, because it's generic, you can't make as much money off of it as you could if you develop a new drug. So what some of the drug companies have done, and in this case, Janssen, is they developed they created a formulary of the S plus version of ketamine, or esketamine, and that gained FDA approval for psychiatric purposes, specifically for depression, treatment-resistant depression with suicidal ideation. That gained limited FDA approval in 2019. So as you can see at the top bullet point up there, so racemic ketamine is not FDA approved for psychiatric treatment, even though physicians and psychiatrists do have the latitude to provide that off-label. But if we're talking strictly about FDA approval, Spravato, which is the trade name for esketamine, is the only form of ketamine that has any kind of FDA approval. And the FDA approval for it is a very limited FDA approval. It is only through what they call the REMS safety program, Risk Evaluation and Mitigation Strategy Program. And so apropos of that, esketamine, Spravato, can only be provided in certain settings where patients are carefully monitored, particularly their blood pressure. There's a certain number of physicians on staff, and it's a very controlled environment. Now, in my work and in my practice, I work closely with a psychiatrist. Some of you may know Dr. Lucien Manu. He's the director of the outpatient clinic at Stony Brook, but he also has a private practice in Woodbury. And so he was spearheading the Spravato trials at Stony Brook for a number of years, not just leading up to the 2019 FDA approval, but after that. And at that facility, the Spravato is really the only form of ketamine that they offer. The trial has ended, but they strictly use the Spravato. In his private practice, he has more latitude to offer the racemic ketamine, which he typically does. Okay, so now there are, in addition to those two versions of ketamine, the racemic ketamine and the esketamine, whichever form of ketamine we're talking about here, it can be administered in any number of ways. The most common are intranasally with a nasal spray, injection, which could include an intramuscular shot or a subcutaneous shot, or an IV drip. Also, it could be offered orally through a sublingual, a wafer that's taken and used sublingually, as well as a pill or a lozenge that you can suck on or swallow in the case of the pill. So now, what are the differences between the different administrations of ketamine? Well, different administrations of any drug have different levels of bioavailability. So anything that is taken orally goes through the liver, for those of you who may remember from school, the hepatic first pass. A lot of it gets blocked out. Generally speaking, injections through intramuscular, but especially IV, that's the most efficient delivery of any drug, and in this case, ketamine. And typically, it's not only absorbed better, but because it's absorbed better, you don't have to use as high a dose, which typically means fewer side effects. But it also means that the experience is a lot more even and level. When people are taking the nasal spray, that has become the most common form now because it's non-invasive. So the Spravato is only offered as a nasal spray. Racemic ketamine is offered in all of these forms, but Spravato is only offered as a nasal spray. Now, the positive thing, I guess I'll get to Spravato here. Well, not just Spravato, but also racemic ketamine offered as a nasal spray. So there are different dosages of how this is delivered. So up top, we have esketamine and the different dosages. So if you see in the picture, that's a spray bottle. Each spray bottle has 2 sprays in it, and each spray is 14 milligrams. So the spray bottle itself has a total of 28 milligrams. Typically, well, officially, I should say, from Janssen, they'll say that the maximum dosage of Spravato should be 6 sprays or 3 spray bottles. But unofficially, in my practice and my work with not only Dr. Manu, but other psychiatrists, I've seen people go up to 20 sprays for a dosage of 280 milligrams. Racemic ketamine, if you could see, below, it's the doses, the dosage is actually a little bit less. So it's 10 milligrams per spray. And in the racemic ketamine spray bottles, they typically have a lot more than 2 sprays. They might have 50 or 60 sprays worth of racemic ketamine in them. And here, again, officially, the dosage shouldn't go above 200, but in unofficial capacities, I've seen people go as high as 60 sprays, 30 sets of 2 sprays. And so that would be a dosage of 600 milligrams. When we're talking about ketamine injections, so as I said earlier, let me just go back here. So with ketamine sprays, the experience for the patient is typically, one of climbing a mountain, and then they stay at the top of the mountain for a little while, and then they come down. And that's pretty much their experience, and that total experience lasts about 45 minutes. But with the IV ketamine, the experience is a lot more level and even. So once you get that initial infusion, it's pretty continuous. You're getting that drip, and it's a pretty steady and continuous experience. You don't have these, kind of peaks and falls during the whole experience. Because it's intravenous, the bioavailability is very high. You're bypassing the liver, so it works very fast. Now, IV ketamine or intramuscular ketamine, this is not yet approved by the FDA for psychiatric treatment, but it is given off-label by psychiatrists and other practitioners. In terms of the dosing, so the dosing is done a little bit differently. As with most IV medications, the dosing is done by weight or mass. So typically for an IV, the max dose would be 1 milligram per kilogram. And if we think about the average man being about 200 pounds, which equates to 91 kilograms, that's about 91 milligrams of ketamine, which is a lot lower than the intranasal version, which could be up to 200 to 300 milligrams. For a woman, it's even lower. Typically, a woman around 130 pounds, 59 kilograms, 59 milligrams of IV ketamine. And then with intramuscular, it's not intramuscular drugs are not absorbed as easily as intravenous drugs. So the doses are typically a bit higher, in this case, double. So the max dose is 2 milligrams per kilogram. So the average man, max dose would be about 182 milligrams, the average woman, about 118 milligrams. Then you have the oral ketamine, which has even lower bioavailability than the nasal spray. This is, not nearly as common, but is increasing in popularity because this is really the only form of ketamine that people can take at home. Typically, you're not set up with an IV at your house. And even with the nasal sprays, this is not done at home. This is done in a doctor's office somewhere. This is, you have a lot of companies now, particularly telehealth companies that, are using, or depending on your perspective, maybe exploiting the flexibility that physicians are given for prescribing things off-label, and in this case through the mail. And so because reactions to ketamine can sometimes be unpredictable, I really don't recommend doing this at home and not with the supervision of a physician on hand. So what can ketamine treat? Well, first of all, from an FDA perspective, ketamine is only available for adults in the limited FDA approval for esketamine. Off-label, there are psychiatrists that will provide ketamine for adolescents, but that is not very common. But it does happen. It can happen. It's allowable. Initially the conditions that ketamine is predominantly used for different forms of depression, major depression, bipolar depression, as well as treatment-resistant depression for people who've failed any number of antidepressant trials and things of that nature. However, in my experience, and as well as in the research, ketamine is very effective for PTSD, and even OCD and other anxiety disorders. And in the case report that I'll talk about later, the one that I had published in December, the woman that I worked with who had made such considerable progress on ketamine, it was really in her trauma-related symptoms, her PTSD-related symptoms, and a number of the other correlates to her trauma. So what does it feel like to be on ketamine? Well, number one, you're very relaxed, typically. You also have this experience of dissociation. A number of patients have said to me that it's almost like an out-of-body experience where they feel like, if this is their body, they're up here kind of observing their emotions, but not feeling the emotions. And, that kind of leads to, what we call a trance-like state. And for reasons that will be discussed later, it's this part of the experience, both with ketamine as well as psilocybin and the other psychedelics, that is really the most important part of the experience. Because what this allows people to do, particularly in a ketamine-assisted therapy context, is to approach situations in their lives and in their memory with little to no anxiety, and to see them much more clearly. And from a psychodynamic perspective, I practice predominantly psychodynamically. There's sort of a numbing or a dissolving of the defense mechanisms. And that offers such a tremendous opportunity for patients to really get to the core of either their trauma or their depression or their symptoms in ways that would not be possible if the ketamine or the psychedelic was not being administered. Another part of the experience is that there are subjective distortions of time. So like I said here, 1 hour feels like 5 minutes. There's also some people experience synesthesia, so they can smell colors and see sounds, all that kind of stuff. One particular patient of mine said that he just experiences the whole dynamic in terms of colors, where this is the blue part of the experience and this is the orange part of the experience. Colors are just a major part of this. A lot of times, something that Dr. Manu often does, and it's typically done in a lot of ketamine clinics, is music. There are playlists that are specifically dedicated to psychedelic treatments, and in this case, ketamine treatments. So Dr. Manu has dozens of playlists, some of which are spoken word meditations like Alan Watts. John Hopkins has a series of playlists that includes both music and meditations. And, online you can find these playlists and these musical accompaniments to the experience. And these things really curate the experience for people. Another patient, when I had done a psychedelic-assisted therapy session with her, she experienced me as an emoji. Obviously, that's the more psychedelic part of the experience. So depending on the dose, there are a lot of factors at play that determine how the experience goes. So one factor is what dose people are on. Another factor is whether they've had anything to eat that day. Another factor is how long it's been since their last ketamine session. What we've found is that when there's a habituation to the regular ketamine treatments, and at a certain point, the psychedelic parts of the experience start to wane, and the thing that remains is just the relaxation and the dissociation. But then when people take a break for a week or 2 weeks, they often have a much more powerful session, and usually the psychedelic components return after that. And typically, in my experience with Dr. Manu, and I have about 10 to 15 patients who are either taking ketamine or psilocybin therapeutically. Most of them are taking ketamine, though. The most common protocol is for them to be having a treatment once a week. And then sometimes, I would say once every few months, I will do a ketamine-assisted therapy session with them, where I'm actually in the room with them and I'm talking them through the experience, and we set intentions and we set goals ahead of time. So there are lots of factors that determine how the experience goes, from, just simple relaxation, on one extreme, to a psychedelic experience where, again, people are seeing any kinds of visual distortions and whatnot. Although, sometimes a lot of people go through the experience with blindfolds on, and I think that's actually a very good way of going through the experience. Oh, go ahead.
And John, we have a question
Sure.
from Melissa Schroeder.
Yes.
Great question. Any caveats for these disorders with psychotic features? So going back to 2 slides ago.
Yes, exactly. So thank you, Melissa. Yeah, you're a step ahead of me. So ketamine is contraindicated for people who are at risk for psychosis. So what does that mean at risk? Well, if they've had any kind of psychotic episodes in the past, or if they have a family history of it. And now, even amongst people who don't have that history, sometimes there can be, what we would call transient psychotic symptoms in the hours or the days following. But in my experience, well, first of all, I don't think anyone in my experience has had the transient psychotic symptoms. But anything that I've heard about them is that they've been, typically brief. So thank you, Melissa, because yeah, that's important. Another contraindication or side effect is that for people with addiction histories. Now, obviously you can't get Spravato very easily. You can't get racemic ketamine, very easily, the way it's dispensed, but there's a black market for every drug and every medication. And many of you are probably familiar with ketamine as a street drug. Obviously, it also has use in veterinary contexts, particularly for horses, but also as a tranquilizer for other animals. So, anytime you have a drug like this, there's always going to be the potential for a black market type of situation evolving and people being able to abuse it. So ironically, and here's sort of the paradoxical and ironic thing, not only about ketamine, but about psilocybin, and even more so with psilocybin, is that both of these psychedelic drugs have actually shown to help people overcome addiction, and they're used in that context. So addiction from, heroin and cocaine and other things, that both ketamine and psilocybin have shown efficacy for remediating addiction in a number of cases, and alcoholism as well. So there's a whole literature on that. One of the other side effects or class of side effects for ketamine is in the cardiovascular realm. And so if in all the medical situations where you see people are taking ketamine or being administered ketamine, you'll always see a blood pressure monitor. They're continually hooked up to a blood pressure monitor because blood pressure can spike 30, 40, 50% sometimes. So people who have a history of cardiovascular disease or at risk for heart attack, stroke, those are people who should not be taking ketamine therapeutically in this particular context. Other side effects with lower frequency include bladder and urinary problems, some temporary memory impairment. Although, they're, again, sort of paradoxically, like with the addiction stuff, because ketamine and the other psychedelics are involved in synaptogenesis and neurogenesis, creating new neurons and creating new synapses, paradoxically, there have been small reports of improvement in dementia-like symptoms with some of these psychedelics, but there's a lot more research that needs to be done, I think, before any kind of clear correlation is identified between some of these psychedelics and improvement in dementia. Physical injury from accident after treatment. Okay, so the after effects of ketamine typically last for several hours, if not for a day or two later. So at any of the clinics that you'll go to, at Dr. Manu's clinic at Stony Brook or also at his private practice, you're not allowed to drive home. You need a ride. You need a ride home. So, you obviously shouldn't be operating any other heavy machinery because you're still experiencing after effects even the next day. So, in real world situations, most of my patients are able to drive or do things probably about 2 to 3 hours after their session, but they should definitely not drive home from their session. One of the other side effects is falling into a K-hole. And what the F is a K-hole? Okay, so K-hole, if you're not familiar with the term, it's a slang term for really a bad trip and bad ketamine trip. And it can be scary. I've had patients who've had K-hole experiences. Essentially, the scariest part of the experience is that you feel immobilized while you're having this dissociative state, sometimes with hallucinations or other psychedelic effects, and you may not be able to communicate, you may not be able to talk. And so, you may feel trapped in a way, and that's, can obviously be a scary feeling that could lead to panic. It may include dizziness, or it may cause dizziness. People feel like they're melting into their surroundings. Another more positive way of putting that is, you feel a sense of oneness with the universe. But a patient of mine who had a K-hole experience a few months ago said that the way he put it was, I felt like I was having a panic attack in outer space, which, as you can imagine, is pretty scary. What I will say, though, and a number of my patients have had K-hole experiences. None of those experiences were significant enough for them to stop taking ketamine because of the K-hole experience itself. And so for virtually everyone who's had the K-hole experience, they still felt that the benefits of ketamine and ketamine treatment outweighed the anxiety-provoking experience of a K-hole.
And I
Okay.
actually had a question on
Yeah, go
that.
ahead, Laura.
Is that due to the dosage being too high, or were they stressed by another factor? What is usually the factors related to the K-hole
Yeah,
happening?
great question. It's not completely clear, but what I will say is among the patients that I've worked with who've had K-hole experiences, in some cases they were sick, like they went to a ketamine session, like being sick, having a fever or something like that. Or you're not supposed to eat immediately before ketamine session, but you should have had something to eat like 3 to 4 hours before the ketamine session. But for some people, if they didn't eat at all, like they were fasting from the night before and they didn't have anything to eat at all, there's been, some correlation with, K-hole experiences there. And yeah, sometimes if the, dose jumps too high from one session to another, these are some of the correlates that have been, associated with some of the K-hole experiences among my patients. So, we're just about we're at the halfway point here of the talk, and so I guess the talk is going a little faster than I expected. So we could either take 5-minute break if people need to go to the bathroom or get something to drink, or if anybody has any questions. So Laura, I'll leave it up to you if you want. We could take a few-minute break, or if there are any questions.
It's a good, yeah, let's see if the silence allows some questions to come up. And otherwise, if the attendees need to use the bathroom, get a drink, feel free to use this time. We'll just allow some space for questions at this point. Or John, if you need a break, let me know, because we could also do that.
Okay. I'm just gonna get something.
I did have another question. I don't want to ask
Yeah, go
so
ahead.
many questions, but one of them had to do with history of substance use. And I know you talked about how it could be potentially, misused in ways, but it also has been found to be helpful for people to overcome addiction. So is there something is that a factor you look at, a person's history with addiction as to determine whether they're appropriate for ketamine assisted therapy?
Yeah, yeah, great question. I I you know, I don't have enough experience personally, even though in the literature there's growing evidence that the psychedelics and ketamine in particular have shown efficacy for help with addiction issues. I don't have enough experience with that yet. So I will typically defer those types of cases to somebody else to see, what their comfort level is. If, I have someone that I'm working with who has depression or PTSD and comorbid, has an addiction issue, I would be very reticent to recommend them just yet for ketamine treatment. I think, I would still like to see more evidence on how people do with addiction issues that, are taking ketamine.
Okay. Yeah. And similarly, are there guidelines to substance use while under or, participating in ketamine assisted therapy, such as THC use, alcohol use, things like that?
Um, I don't believe with THC. I know that some psychiatrists, Dr. Manu included, will tell his patients to not take some of their regular psychiatric meds on their ketamine session days, particularly like
Mhm.
mood stabilizers can interfere with or interact with. Um, but in terms, I mean, obviously, well, all right. So you know what? This is a good opportunity to talk about Matthew Perry because he had a
I
very
was thinking about Matthew Perry. Yeah.
yeah,
Mhm.
he had a very highly exposed fatality. And even though there was ketamine in his system, number one, there were a number of other drugs in his system. I forgot, I'm not sure if there were also opioids in his system, but I think he had also taken a dose of ketamine that was like a surgical dose of ketamine, which is like, 10 times the amount that you would typically take for depression or in a psychiatric context. And
Mhm.
if I remember correctly, you can correct me if I'm wrong, but I don't think he had died from the effects of the drug or drugs directly. I think he had drowned in a hot tub, right? Uh,
Right, due to cardiac arrest. And yeah, I
right.
mean,
Yeah,
I,
it's
I I know just some of the, facts, right? But yeah, it seemed like it wasn't related to the therapy itself, but
yeah.
was, ketamine that might have been taken after therapy because of the time difference. And but yeah, that's something that I was curious about. We have two questions in the
Yeah.
chat too. Um, so Melissa, Melissa Schroeder asked, I imagine there are implications and risks for patients receiving ketamine treatment without close following with a psychologist. Is there a lot of collaboration between the psychiatric providers?
Between like psychiatrists and psychologists. So that's a really good thing to bring up, is that and that actually kind of segues into the next. So actually I'm gonna Melissa, I'm gonna put off your question for a minute because that kind of segues to the next slide. So I'll take the other questions first, and then
Sure.
Melissa's question should hopefully be answered by the next slide.
Okay, great. And Tony asks, any reports of encountering God or spiritual awakening, which is a very interesting question.
Yeah, very, it's a very, very common thing. And people who are, not religious or resistant to spirituality, particularly in the case report that I'll present later, this was a woman who really had been, jaded by religion and resistant to religion and spirituality. And her experiences were just so extraordinary that she's kind of come out the other side. It's pretty profound the way she kind of thinks about things now. But yeah, regardless of what people's beliefs are going in, there is something transcendent about the experiences. Now, whether you want to call that spiritual or God, godlike, that's up to you. But there's something transcendent about the experiences, both with ketamine as well as psilocybin. And for a number of the researchers and clinicians, they feel that that is one of the active ingredients here, that when you have this transcendent experience, it puts everything else in a totally different context than what you had before.
Great, thank you. And that's all the questions for now. So you want to get into the second part? Okay.
Sure. So ketamine-assisted psychotherapy can mean a lot of different things. We're really at the ground floor here of something that is being built, and 50 years from now, it's going to look very different. I know psychedelics have been used for thousands of years, and psychiatrists have been experimenting with them. Well, of course, we know Timothy Leary and Richard Alpert, who eventually became known as Ram Dass, were experimenting with LSD in the 50s and 60s. But in a more formal way, we're kind of on the ground floor of how this is to be done. And there are ketamine clinics popping up everywhere. There are psychedelic retreats popping up everywhere. The type of therapy that's offered in these facilities varies greatly. And what I will tell you is that what Dr. Manu and I have tried to do, and what I've tried to do specifically, is a bit different than what is done at a ketamine clinic or a psychedelic retreat. When you go to a ketamine clinic or a psychedelic retreat, even though the ketamine is the same, you are encountering a therapist, often for the first time, that really doesn't know very much about your history and isn't able to bring to that session much more than what they were able to glean from an intake interview. That is a qualitatively different experience than I think what I've tried to do, in that I will only recommend one of my patients for ketamine treatment after I've been working with them for at least 6 months. And now, there are people who get ketamine treatment without any psychotherapy, and they experience benefits and a relief of their depression or anxiety. But the therapy component I think is really important. Now, some people get ketamine treatments and they're doing therapy on the side, but they never mix the two. They just, will go for their regular weekly therapy session, and that's separate from their weekly ketamine session. What I've tried to do with my patients, and again, I work psychodynamically primarily. I've been trained in cognitive behavioral therapy and in family systems therapy, and a number of other approaches. But by default, I work primarily psychodynamically. Um, you know, I I try to do a joint session with Dr. Manu during a ketamine treatment only after I've been working with someone for about 6 months or more, because and the longer that I've been working with somebody, the more I can bring into that session. And I think from my perspective, that's really where the magic happens, because knowing somebody for, 5 years, 10 years, 15 years, I can bring so much more to one of these ketamine trance-like states to ask people about than, a therapist that might be meeting a patient, that day or on the spot. And even though, they can help guide them through a certain protocol, and they can help guide them through talking about their trauma and certain past experiences, um, from my perspective, there's no substitute for having years worth of knowledge. Even if you're, practicing from a CBT perspective or an ACT perspective, acceptance and commitment therapy, uh, that, to me, the style of therapy, the mode of therapy is less important than how long you know the patient going into your ketamine-assisted psychotherapy session. And, what I've found is during these ketamine-assisted therapy sessions, people make progress that would not have been possible either with the therapy alone or with the ketamine treatment alone. The ketamine, so let me take a step back here. One of the interesting things in the research is that researchers and practitioners have found that regardless of which psychedelic drug we're talking about, whether it's ketamine, whether it's psilocybin or something else, there are different ways of administering it. There are different dosage levels. In the case of psilocybin, there's the potential to microdose. You can't really microdose with ketamine, because microdosing really involves taking a small dosage daily over a long period of time. And for the reasons we talked about previously, that's not really possible with ketamine, because this needs to be done in a clinic and with medical supervision and such. So, but what researchers and practitioners have learned is that the psychedelic dissociative trance-like state that often occurs when you've given a certain level of the psychedelic drug, that is a necessary component for the psychological transformations to occur. And so, the obvious question is, well, why is that? And, some of the researchers, from their perspective, they'll say that, ketamine promotes access to difficult experiences and states of mind with less fear, and, a relief of some of the obsessions and the depressive mindset, so that when they revisit some of these painful memories or experiences or cognitive states, they're doing so from a totally different, a totally detached perspective, and they're able to see these memories and these past experiences from a much more objective perspective. Now, as a psychodynamic practitioner, what I would say, and I guess the language that I would use, is that these psychedelics, and ketamine in particular, dissolves their defense mechanisms. That people are able to approach things that are otherwise threatening, otherwise would create a panic attack, and they're able to revisit them and even work through them. More than that, one of the ways that I work with patients when I'm doing a session like this is almost using the power of suggestion the way a hypnotist would, or someone who does hypnotherapy. That I will work out in advance with a patient a certain intention or a novel perspective and way of looking at a past experience. And then when they are under the influence of the ketamine, I will then bring that up to them again, and it will penetrate into a deeper level of their psyche than it would have during a regular therapy session. And, for one particular patient who is given to anger and rage episodes, but also has health concerns, the thing that I sort of implanted during one of his ketamine sessions was that anytime he has a rage episode, it leads to inflammation in his brain. And when he has inflammation in his brain, he's much more likely to have attention issues and other health problems that he's concerned with. And, interestingly, after we had that joint session, he has been much more committed to cutting off or nipping in the bud situations that would otherwise lead to a rage attack or losing his temper in one way or another. So, interestingly, the benefits of this dissolving of the defense mechanisms isn't just about what can be pulled out, it's also about what can be put in. And so, kind of offers some really interesting and powerful opportunities. Okay, so what I will do now is this is the last thing that I had on my agenda for today, and it had a little bit this take up a little bit of time. I wasn't quite sure how long the talk was gonna go, so that's why I left this at the end. And since we have 45, 50 minutes left or so, we have the time. So in almost exactly a year ago, in January 2023, I did a I did a ketamine-assisted therapy session with a longtime patient of mine. I'd been seeing her about 4 or 5 years at the time. And we had such an extraordinary session that almost immediately when I got home, I started writing it up as a case report. It's interesting when you're in the midst of something sublime. um you're kind of uh witnessing something in real time that is kind of beyond the pale. And I had this experience with her where I was just, I just couldn't believe what was unfolding in this session. And so I like I said, I started writing it up that day and sent it out to this journal, Psychodynamic Psychiatry, a couple of weeks later, and they accepted it, very quickly. And then it was finally published in December. So, I thought what I would do here, I think this case report highlights not only the power and the benefits of a ketamine-assisted therapy session, particularly with someone that you know for a long time, but for those of you who are psychodynamically oriented, I think it does offer a good way of understanding or analyzing someone from a psychodynamic perspective, and the different components involved. So what I'm going to do here, can you still see the can everybody still see the display on the screen? Yes. Okay. So I'm just going to read here because I have this open in another window. Okay. So the pseudonym for this particular patient is Elizabeth. Elizabeth is a 54-year-old woman who was raised and currently lives in a suburb of New York City. She's the youngest of 4 children and grew up in an Irish Protestant family with a father who was a stationary engineer and a mother who was a homemaker. During her intake, Elizabeth initially described her childhood home as, quote, regimented, largely due to her mother having obsessive-compulsive tendencies about neatness. However, I can share this screen, actually. Maybe I'll do that. This way people could follow along. Okay. So you can see that now, right? And over here. However, Elizabeth also made a point to clarify. I'm at the top of 470, just below patient's background and history.
You might want to maximize it a bit
Oh,
as
okay.
it's small on the screen.
Okay.
That's good. Yeah.
Okay.
Thanks.
Okay. All right. So here I am right here. Elizabeth also made a point to clarify. Just have to move this here. That the home in which she was raised was a happy one. She spoke of her parents as having a strong relationship with each other and said that they both took considerable interest in her, making her feel as though she was the favorite child. The first of Elizabeth's multiple traumas occurred at age 15 when she was robbed at gunpoint and raped by a masked home invader while babysitting on New Year's Eve. Though she believes the perpetrator may have been the brother of a friend, this was never confirmed. After the incident, Elizabeth reported the robbery to her family and the police, but she never felt she could tell her parents about the rape because she feared they would not be able to handle it. In the years following, Elizabeth learned to either repress, suppress, or sublimate feelings of vulnerability. This allowed her to persevere through myriad obstacles, eventually becoming a universally respected assistant principal at a local high school, as well as a successful triathlete. Regarding the latter, Elizabeth came to adopt a mantra of the Marines, that pain is weakness leaving the body. In her efforts to clear the hurdles she confronted, both physical and emotional. In her early life, Elizabeth was exclusively heterosexual and dated several men, but never felt connected in her romantic relationships until she met Stephanie in her late 30s. She and Stephanie, who was previously married to a man, fell in love and got married in 2013 when Elizabeth was 44 years old. The second major trauma Elizabeth endured was an accidental fall in 2011 after slipping in her driveway. The injuries she suffered, dislocation of a cervical disc, and the subsequent surgeries it required, i.e. a spinal fusion and 5 spinal leak revision surgeries, left her with permanent, chronic, severe pain in her neck, shoulders, and back. Complications from this injury led to 4 additional traumas in the form of near-death experiences following medical procedures at 2 different hospitals. In addition to those events, Elizabeth's most recent slow motion trauma has been the gradual loss of functioning in her upper body and throat as part of what is now believed to be the progression of primary lateral sclerosis, PLS, which is a form of ALS or Lou Gehrig's disease. Okay. Psychotherapy. Elizabeth began psychodynamic psychotherapy with me in January 2019, about 8 years after the tragic fall that left her with permanent spinal damage and chronic pain, and I gave her a diagnosis of post-traumatic stress disorder, chronic. Before her injury, Elizabeth had strong, if not blind, faith in the medical establishment, which she greatly respected. However, after complications from multiple surgeries worsened her condition, and aftercare regimens became increasingly problematic, Elizabeth's faith in all things medical began to erode, especially since she had been treated at various points by two of the world's most distinguished hospitals. Elizabeth expressed early in therapy feeling helpless, scared, and in need of hope. Although outwardly she was jaded towards organized religion, her insistence in calling me by my initials, JC, seemed to make salient an unconscious desire for me to serve a supernatural purpose for her. Although I was aware of Elizabeth's transference to me, I did not immediately bring it to her attention. At this early stage of therapy, given the life and death circumstances she was confronting and her growing disenchantment with the medical establishment, I worried that such an interpretation of her transference would upset her and lead her to quit treatment. This aspect of Elizabeth's transference was my first experience with her tendency to idealize people that she cared about, putting them on a pedestal. It was not until much later that I realized her desire to call me JC, and my avoidance of discussing this with her was an inverse enactment, signaling back to the aftermath of her rape at age 15. More specifically, I adopted the role of 15-year-old Elizabeth, who previously chose not to tell her parents about being raped because she feared they could not handle it. But by choosing not to tell adult Elizabeth something I feared that she couldn't handle, essentially I was doing the same thing. In both cases, the withholding of essential information served the ostensible purpose of protecting the others, but on an unconscious level, it enabled each of us, respectively, to avoid being pushed off the pedestals we were on. Her off the pedestal her parents put her on, and me off the pedestal that she put me on. Though my intentions were good and the option I chose may have ultimately been the best one available, my decision to avoid discussions with Elizabeth about her putting me on a pedestal still had a negative consequence. It stunted her psychological development. More specifically, it prevented her from seeing how this same dynamic played out in so many other relationships in her life, often to her detriment. It was not just me that Elizabeth placed on a pedestal, it was also her wife Stephanie, her closest friends Diane and Nora, and each of her parents. Elizabeth's pedestal relationships played out in one of two ways. If someone she placed on a pedestal was in conflict with anyone else not on a pedestal, the person on the pedestal could do no wrong in her eyes. This led to one set of negative consequences, with her discounting the feedback of those individuals who were not on a pedestal, including certain doctors, culminating in decisions that sometimes led her astray. However, when conflicts in Elizabeth's life involved two people on pedestals, the ambivalence, anxiety, and tension that resulted led to a different set of consequences. First, Elizabeth would try to withdraw from each person to avoid taking sides. However, her significant medical and physical needs would eventually require that she reestablish contact with one of them because she could not survive for long without the extra help. This predicament would place Elizabeth in a double bind, knowing that reestablishing contact with just one of these two individuals would put her at odds with the other. Fittingly, it was then that Elizabeth would usually experience an exacerbation, if not escalation, of her physical symptoms, eliciting great concern among all parties involved, and ultimately leading the two people in conflict laying down their arms and rallying around her. Given the existential depression that Elizabeth was suffering in response to her progressive physical pain and degeneration, along with the multiple layers of family strife, including marital discord with her wife, Stephanie, Elizabeth decided to pursue ketamine treatment in the fall of 2022 as an adjunct to her existing psychodynamic therapy with me. In early 2022, I learned that a psychiatrist colleague, Dr. Lucien Manu, was spearheading the clinical trials of esketamine, brand name Spravato, at Stony Brook University Medical Center, and almost immediately I recommended Elizabeth for the trial. Though our therapy had been going well and she was having exciting insights into her behavior, she was still in conflict with many people in her life, her wife, her brothers, and some of her friends. And she was growing despondent about the progression of her PLS and the increasing problems with swallowing that it caused. The official esketamine trial had a long waiting list, and Elizabeth felt she needed treatment as soon as possible, so she began seeing Dr. Manu privately for racemic ketamine treatment in the fall of 2022. Like so many of the people I had seen in documentaries about ketamine, Elizabeth experienced an instantaneous elevation of her mood with treatment, and the positive effects lasted longer and longer after each 90-minute treatment session. Elizabeth began getting treatments once per week, taking ketamine via intranasal administration. After 2 months of therapy, the improvement in her mood and outlook was so striking, I asked if I could sit in on a session to observe. Elizabeth not only agreed, but proposed the idea of me giving her a psychodynamic psychotherapy session during one of her ketamine treatments. I was open to the idea, as was Dr. Manu, and we set up a joint session for the end of January 2023. What followed during this joint session was one of the most memorable psychotherapy sessions of my career. Below is my progress note for that session. Today's session with Elizabeth was a joint session with her psychiatrist, Dr. Manu, during one of her weekly ketamine treatments. Over the course of this 90-minute session, Elizabeth took 10 sprays of racemic ketamine in each nostril, total dosage 200 milligrams. While under the influence of ketamine, Elizabeth spoke about being able to, quote, cut the cord between her wife Stephanie's emotional reactivity and her own. And then she noted a growing emotional distance between herself and her past traumas. She then described having a, quote, spiritual experience, which was unusual given that she's consistently denied any inclinations towards spirituality. Later, an interaction between us ensued whereby I asked if she felt safe enough to reflect on the most recent conflict between Stephanie and Diane, a lifelong friend from whom she's grown estranged in the past year after a fight with Stephanie. Elizabeth said that she now felt safe enough, given the effects of ketamine, to consider the dynamics of this conflict more deeply than in the past. During this discussion, Elizabeth acknowledged for the first time her tendency to put people on pedestals, including both Stephanie and Diane, making them into personal, quote, superheroes. She spoke about how her need to do this developed after her sexual assault, and then it intensified after subsequent traumas to help her manage the ongoing terror of the many frightening predicaments of her life, and to give her hope for the future. Elizabeth never had the ability to see her idealizing tendencies, i.e. putting people on pedestals and making them into superheroes, from this detached perspective. But she expressed that the feeling of calm she had while on ketamine gave her the emotional distance and courage she needed to see these dynamics clearly. Elizabeth acknowledged that there were times when the superheroes she idealized showed flaws, causing her cognitive dissonance and interfering with her fantasy that they could rescue her from the myriad hardships that she encountered. She then expressed how her response to this cognitive dissonance was to ignore the flaws of her superheroes so she could maintain her rescue fantasies. However, ignoring the flaws of the people she idealized led to an increasing number of conflicts in her life. This was because not all of the superheroes in her life got along with each other, and during conflicts between superheroes, her willful denial of each one's respective flaws led to the other feeling invalidated, and subsequently to them acting out to get her attention. This was particularly the case between her wife Stephanie and her friend Diane. Elizabeth, recognizing that no other person in her life could rescue her from the impasse caused by two superheroes being in conflict with each other, came to understand on an unconscious level that she'd need to rescue herself. She ultimately discovered that by being ill or injured was the only thing that led people in her life to put aside their conflicts with each other. And this gave her, unconsciously, a secondary gain for having deteriorating and escalating medical problems. Elizabeth also acknowledged during her ketamine session that she never realized how putting people on a pedestal could put pressure on them to be perfect and to avoid disappointing her. This acknowledgement gave me the courage to admit to her that I too felt pressure to live up to her fantasized expectations, as I feared that disappointing her would then lead her to push me off the pedestal that she put me on. Until now, this aspect of our transference-countertransference dynamic limited my ability to help Elizabeth because I was withholding information that could have helped her to grow. But today, Elizabeth expressed a desire to know more about these feelings, and she believed that she was now strong enough to handle them maturely. At the end of the session, Elizabeth and I agreed that she would continue to be mindful of her tendencies to split people in her life into superheroes and villains, and she would continue seeing people as they really are. And then there's just a little bit of conclusion. Insights in psychotherapy, like those Elizabeth had during her ketamine-assisted joint therapy session, can be intellectually stimulating for both patient and therapist. But if those insights are not followed up with actionable interventions, they often provide little more than a sugar high. In the weeks that followed Elizabeth's extraordinary ketamine-assisted psychodynamic therapy session, she began making significant changes in her relationships, changes we had talked about for years, but she had never implemented. Little by little, Elizabeth began allowing herself to see the flaws of the superheroes in her life, which accomplished two things. First, it took considerable pressure off of all of us to be perfect, and as a result, all of the people she put on pedestals, myself included, felt it was easier to give Elizabeth difficult feedback. Whereas in the past, the people Elizabeth kept on pedestals feared that she might push them off if they gave her constructive criticism, now these same individuals are able to be more honest with her about her limitations so she can grow as a person, a friend, and a wife. Second, her new willingness to see and acknowledge the flaws in her superheroes, particularly those in conflict with other superheroes, validates the feelings of everyone in her life who might not have seen her superheroes as infallible as she once did. This, subsequently, gives the superheroes in her life less reason to create conflict with each other by pointing out the flaws that Elizabeth was previously denying. In the months since Elizabeth's ketamine-assisted joint therapy session, the frequency of conflict between her superheroes with each other decreased, as has the number of times she has reported an escalation of physical symptoms. Though Elizabeth has not achieved remission of her PLS or the symptoms emanating from her spinal injuries, it is notable that she has consistently reported less physical pain, a greater range of motion, and sustained remission from her depressive symptoms. She has also enjoyed a renaissance in her marriage with Stephanie and achieved rapprochement with many other people in her life, including other mutual friends who were once in conflict with Stephanie. Regarding the latter, it is notable that in April 2023, her wife Stephanie threw her a surprise party that included several of the friends and family members with whom Elizabeth was previously in conflict. Okay. All right, so that is the end of a very long anecdote case report. I apologize if it was a little long-winded. I had decided to go with it given that we had so much extra time. So, we still have a little bit of time left for anybody who may have questions or comments, either about the case report or about anything else in the presentation.
Thank you, John. That was really interesting, the case study, and to see how what happened in the session actually carried over into her real life. Because I was curious about how her pain and her relationship would change after, getting that insight during the session. And we have a question from Anthony. So eligibility is 18 and over or 21 and over?
I believe, I believe for Spravato, it's 18, but off-label, I think, those restrictions don't apply. So there are some psychiatrists who will do it with kids as young as 10, and certainly adolescents. But for the Spravato, I believe it's 18.
Okay. And Melissa asks, in Elizabeth's previous ketamine treatments, did Elizabeth receive any psychotherapy from Dr. Manu?
So Dr. Manu, what I like about him is that he and I are sort of cut from the same cloth, and he also has a psychodynamic background. He will try to do more therapy than the average psychiatrist, but it's still limited relative to what a psychologist will do. So I had been seeing Elizabeth for 4 years. Now it's going on 5 years, 5+ years, of weekly intensive therapy. He began seeing her in the fall of 2022, and her sessions with him, he would chat with her for about 15 minutes before administering the ketamine, kind of get a review of her week. But I'm not sure he was going into the same depth that I would go into with her in one of our regular sessions.
And we have a new question from Sherry Hennig. Can you comment on how those of us who have never made a referral for ketamine therapy might evaluate whether a client of ours might be a candidate? It's a good question.
So typically, I don't consider ketamine. Ketamine is not a first-line treatment, at least not right now. I usually don't consider ketamine unless a patient has failed multiple trials of multiple antidepressants. So that would put them in the treatment-resistant category. However, I tend to have a lower threshold for people who've experienced significant trauma and have PTSD as a result of that trauma, because I think, pharmacologically, there aren't nearly as many options for people with PTSD as there are with depression. So, similarly with OCD, yes, technically the SSRIs, are an option for people with OCD, but I know my most difficult cases are cases of OCD. The medications that are out there don't seem to work nearly as well for OCD as they do for a number of other diagnoses. And that's just my experience. Your experience might be different, but that's my experience. So if it's just depression, I usually wait until they've failed some of the other antidepressants. But if it's PTSD or OCD, I'll have a lower threshold. Now, that will change when psilocybin is FDA approved. Psilocybin, I actually believe, has a lot more potential than ketamine. And there are very few, if any, side effects with psilocybin, medical side effects. And they haven't really established any potential for overdose with psilocybin. If it was a family member of mine, I actually believe in psilocybin more than I do SSRIs, and certainly more than benzodiazepines. And so if it was a family member of mine, I would say, try psilocybin before you try those, because the side effects with SSRIs and with benzodiazepines, I think, are greater than with psilocybin. Now, psilocybin has to be, there are lots of things to consider with psilocybin treatment. That's its own, presentation unto itself. But when psilocybin is FDA approved, and I see it in my group. I have, like I said, some people who are doing psilocybin treatment, some people who are doing ketamine treatment. The people who are doing psilocybin treatment, their progress is not only more significant, but it's more consistent. And, psilocybin is something that is easier to administer, in a number of different contexts, but we're not quite there yet. It's not, FDA approved. And similar to ketamine, when psilocybin is approved, it's going to be, a limited approval. And I think actually, if I understand, correctly, it's going to have to be in a context where there is both a psychiatrist and a psychologist present. But obviously, I don't have to tell you, psilocybin is legal in a number of states for recreational use, and people are using it, recreationally all over the country. Even in states where it's not yet legal for recreational use, people are using it.
Sure.
So, but that's its
Yeah.
own presentation and discussion. So.
And the group that you have with some people, the ketamine-assisted or psilocybin psychotherapy, is it the client's preference that determines which treatment they're going to go for?
So I will say off the record that the people who are doing psilocybin are not doing it officially through a medical context, but they are doing it
Oh, I see.
scientifically.
Okay.
They're doing it scientifically and in a regimented kind of a way. But in those cases, they're using psilocybin instead of ketamine because it's much more available.
Right. Okay.
And so, but I do have people who are getting ketamine therapy who have had a history of using psilocybin in the past. And, in retrospect, looking back, they believe that the psilocybin, is more helpful for them.
Okay.
And
I
at some
see. Yeah.
point they may switch over, but it's still a little inconvenient to get psilocybin, and it's not as regulated, and it's not as standardized, so, and insurance doesn't pay for it.
Right. Yes. And so the FDA approval, it's all kind of hinging on that.
Right.
So we have a question from Tony, which it's very interesting. Yeah, I wonder if we as therapists might grow personally and professionally by our own psychedelic experience. What are your thoughts on that?
Yeah, I mean, I guess I'll throw this out there. How many of you have had any kind of a psychedelic experience?
Only we could see the screens.
I
We could
know, I
see the
can't get
hands
nods,
flat.
yes or no, but maybe people putting it, maybe people don't want to, put it in.
We got a hand. We got a raised
We got some people
hand.
raising hands? Okay. All right, so then I don't feel so bad putting this out there. So yeah, so over the summer, I had my first and only psychedelic experience. I actually had done psilocybin, taken psilocybin. So with psilocybin, the dosing is such that one 1 gram of mushrooms would be considered a microdose. 3 grams of mushrooms would be a psychedelic dose. And then, something in the 6 or 7 gram range is what they would call a heroic dose. I had I did 3 grams myself. But a patient of mine at one point had taken 14 grams, which again was kind of a ridiculous amount.
Very
And
heroic.
didn't have it, yeah, it was like double a heroic dose.
Yeah.
Uh, and so, and even though he had a psychological experience that was way out there, medically, he was perfectly fine. So there was, no, issue with any kind of an overdose from a medical perspective. The the line that he said that I thought was, so funny was, he said, at 3 grams of psilocybin, I felt like I understood God like I've never understood God before. At 7 grams of psilocybin, I was convinced that I was communicating directly with God. And at 14 grams of psilocybin, I was convinced that I was God.
Very.
So, but for my, personal experience, yeah, it was, it was something that I'll always, remember. It was one of the most important experiences of my life. The what was kind of interesting about it from me, I don't know the extent to which other people may have a background in meditation, but I felt that as I was able to meditate in the experience, I was able to go deeper into it. And then as I was having sensory experiences on the outside, my dog would come over and lick me, or somebody would talk to me. It was it would kind of take me out of the experience a bit, but I had more control than I was expecting to kind of go deeper into it. And yeah, I mean, I would say, I achieved a oneness with something that I just called it the all, because I felt that even the word God was too small of a word to encompass what it was that I encountered. But the insights about myself and about this human experience were something that gave me a much better understanding about what my patients have been able to experience. And that was one of the primary reasons why I wanted to try to have this experience in the first place, because so many of my patients were involved in this. And like Tony was suggesting, I thought that it would be at the very least helpful, and at most the responsible thing to do, to kind of have kind of an encounter in this way, so that I could help guide these individuals better, through the experience. So
Yeah, I did wonder about that in terms of to be that provider, to know the experience around it, if that is like kind of a prerequisite or important to understand what the clients are going through.
so I had this this therapy session that I did the case report before I had my own personal experience. So, I think if you're afraid to have a psychedelic experience, or it's not practical for you for whatever reason, I think you can still be a very successful and helpful guide. But when you do have one of these experiences, it just kind of adds that extra layer of depth to the work that you do with somebody. Thank you, Tony.
And we have time for more questions, if or comments, if anyone has comments they want to share.
No, it's Friday night. Everybody should go out,
Yeah.
do something fun, have a drink or something.
But Tony is right. It was such a fantastic presentation, really interesting, and something that I've been so curious about. And Melissa says, really great talk. Are there supervision groups for therapists working in this area?
Yeah, that's a good one. I'm not aware of any, but I would have to believe that they are out there and that they exist. I would guess there has to be a Facebook group. I know that, there are conferences, there are psychedelic therapy conferences, and Dr. Manu is always going to these conferences and presenting at some of them. And, so if this is something of interest to you, there are societies and conferences dedicated to this, and I'm sure there are networks, outward from there.
Good to know. Yeah. Thank you, Lisa. Thanks for the comment. Appreciate it.
Thank you, Lisa. Thank you, Melissa.
All right. Well, if that is everything, all the questions, and I know you shared that you have your contact information in case people wanted to reach out to you. And yeah, so just to close up, thank you again, John. That was fantastic, so interesting, and really wonderful to hear about your experience clinically too. And just from the SCPA perspective, to give everyone a heads up about upcoming webinars, we have our rescheduled webinar from February. It's going to be March 15th, and it's the couples treatment of low-level partner aggression. So that's going to be March 15th. There was an email out about that rescheduling. And the one after that for April is April 5th, Intersections of Buddhist Psychology and Mental Health. And so keep your eyes open for those emails to register and sign up for. And yeah, thank you all for attending. Really appreciate all the conversations and questions. Oh, and there will be handouts from today and the article. And Lisa says she hadn't received your information, John.
Okay, I didn't know if I had sent it, I guess.
Oh, it might not have gone out yet.
Oh, okay. Yeah, I had sent it to Beth and Hillary. And so what I'll do is let me put my email in the chat, and anyone who didn't get it can email me, and I'll just email you directly. SVP Wellness. Okay, so yeah, feel free to copy that, because once the Zoom meeting closes, that's gonna, go bye-bye. So feel free to copy that and send me an email if you haven't gotten the materials. So the materials that I have is, a more extensive summary of the discussion. I mean, if you want the PowerPoint slides too, I could send you the PowerPoint slides, but I have a more extensive discussion summary of this, which can't see my email. It's not in the chat there. Oh, maybe.
Oh, that was just
that just went
yeah.
to, oh, okay.
Here, I'll copy it and I'll put it, I'll
Oh,
send
okay.
it
Oh,
to
I see.
everyone.
I'm gonna put it to everyone there.
Okay.
Oh, you did it? Oh, okay.
Yes.
There you go. Okay, got it. So, and yeah, like I said, the answers to the quiz are, pretty easily identifiable in the summary, also in the PowerPoint. And then I also sent out the manuscript, the publication as well, I guess. So, you could let me know what you want when you email me, and I'll send it to you.
Great. And speaking of the evaluation, since this is a CE granting webinar, there will be a Google evaluation form emailed after the workshop that must be completed to receive CE credits. And any questions can be emailed to scpa.inquiry@gmail.com, and I'll put that in the chat too, in case you have questions about the webinar or the evaluation or CE credits. And I think that is it from the housekeeping perspective over here. I think that's all the information. Thank you all for attending again, and I hope you all have a wonderful Friday night. Thank you again, John, for your time and for sharing your knowledge on this. Really appreciate it.
You're welcome. Thank you, Laura. You did a seamless job. It was really a pleasure to kind of coordinate with you on this, and you handled everything from the questions to the direction of it, perfectly. So thank you as well.
Oh, thank you. I appreciate that. First time, so appreciate that a lot. All right. Well, I will end the webinar then. So hope you all take care. Have a nice weekend, and yeah.
Oh, you know what?
Oh,
One question. I don't know if any. One question that I have. I don't know if any of the attendees have an interest as well. But do you know if the recording or the video will be made available in some way?
so all webinars are available on SCPA. I believe that I'm not fully sure if it's going to be available to every attendee without purchasing again. Because if you go to the website, you could see there's a webinar, past and present webinars tab. So if you go there, you'll see the list of webinars. So this recording will be there, and I'm just unclear if you'd have to pay the fee. Someone here might know better than me about that. But yes, it will be available on the website.
Okay, thank you. Thank you so much.
Yeah, I'm probably to you because you're the host, so I'm sure that works. Or so yeah. Any other questions? Anything else? All right. Well, that's, I mean, a little bit earlier, but kind of just on time. So wonderful. Thank you guys so much. I hope you have a great evening, and take care.
Thank you, Laura.
Thanks, John. Take care. Bye.